Welcome to Washington Hospital Today, the program dedicated to sharing timely information about the community hospital that's been taking care of Washington Township Healthcare District residents since it opened in 1958. Washington Hospital Today is provided for the sole purpose of informing residents about healthcare topics and issues that have been covered during community forums, free health and wellness classes, or as part of educational sessions held during the district's open board meetings. This program is one more way that Washington Hospital helps empower you, the residents of the district, by providing information needed to make informed decisions about your health.
I was looking around for something appropriate for hearts, to signify hearts, and I thought that was kind of a cool picture I found on the internet. But what we're really going to talk about is how to prevent a heart attack. And I think some of you folks, from what I can see, have already had one. So this may be old hat for you, but for those folks who haven't had one yet, hopefully we can prevent that from happening. And that's really the goal today. I think the first issue, of course, is what is a heart attack? It's not so obvious. I think the heart attack you can define in terms of the way it presents, with chest pain, for instance, or somebody getting really sick or dying suddenly. But what's really going on is this is a picture of the heart here, and there's three arteries that go on the surface of the heart, one on the right side, one goes down the middle, and one goes down the left side. And if one of those arteries becomes blocked, a lot of cholesterol in here, a blood clot could form, and it blocks off the blood flow so that this area of muscle then goes ahead and dies. And the onset of that is usually signaled by chest pain or some other symptom, and that's your heart attack right there. Is the collection of cholesterol that occurs in the artery, and then eventually it gets blocked off. And if you look at the electrocardiogram, the evidence for it is here. This is a normal EKG up here. And if you just look at this lead and this lead here, 2 and 3, you notice how different these are. This is 2, this is 3 here. And these changes here in the EKG, so over on this side, this EKG here, they're called tombstone ST changes. And tombstone for obvious reasons, because usually this turns into something really bad. And this is what signifies. So when they do an EKG in the emergency room, these are the sorts of changes they're looking for to signal a heart attack. Because what you may have, the chest pain that you may have, may be a heart attack, but it may be something else as well. The actual sequence of events that starts off in men, this would be a 8-year-old artery here. This is what your guy's arteries looks like at 80. This is also what a woman's artery looks like at 50. Looks nice, no cholesterol buildup, almost regardless of what her cholesterol is. And then gradually over time, you start to get a buildup of this foamy material underneath the surface of the artery. It gets bigger and bigger until it finally forms this plaque. It's what they call a vulnerable plaque. And why they call it vulnerable is that there's this cap of tissue here that protects this area from the lumen, from where the blood flows here in the center of the artery, and this area protects this area from rupturing, and actually over time, as I'll show you in a second, here's the whole artery itself, and if you look here, this is a pretty big channel, but there's a fair amount of cholesterol buildup there, and this is even more, and actually the cholesterol can crystallize. These are crystals of cholesterol right underneath the surface. So this is the basic substrate of a heart attack right here. Those crystals that form are the things that set up the stage for inflammation in the artery that eventually causes a crack to occur in the surface of what they call the endothelium, or the inner lining of the artery here. And that crack itself isn't very significant because it doesn't go all the way through the core, but occasionally, let me go here, when it does go all the way through the core, you get this big blood clot here, and there's your heart attack. So this artery here is wide open. And so if you go back and you look, this would be the sequence of events over time here. So again, a guy at the age of 8 or a woman at the age of 50. So the guy takes maybe 40 years to get to this point out here. A woman takes only 10 years to get to this point. So there isn't one difference between men and women. In women, this is a much more rapid progression. In men, it's a much more slower progression. Men can develop protective mechanisms, so when they have their heart attack, they're not so much at risk as women are. Women, when they get their heart attack, it's a much more unstable, much faster event and can cause much more trouble. But in any event, if you follow this along here, if you look at the size of the artery here versus down here, it's about the same. So the blood flow through this vessel is good, but there can be a huge amount of cholesterol underneath the surface of the artery. And if you do an angiogram on somebody, just to kind of figure that out, and you look here, this is a picture of an angiogram. This is the front artery here, and this is what they call the circumflex. This is another front artery. It doesn't matter particularly, but right there it looks a little bit narrow, but not bad. Good blood flow in this thing. And if you stick a ultrasound catheter down there and you look at the inside of the artery, which is what we can do, you see that the inside of the artery is good here, but there's this huge plaque in the artery. And this is the thing that happens over a period of 4 to 8 hours. So that crack appears. So you have your normal stress test in the morning because this lumen is nice and big. And then for some reason, this thing cracks open. A blood clot will form here initially. You'll get some chest discomfort for a period of 3-4 hours. And then if that plaque resolves itself or that clot resolves itself, then the heart attack stops and it doesn't progress. If another clot forms on top of that first clot, then that artery closes off. So you go from an artery that had great blood flow in the morning to one that caused a major heart attack in the afternoon. And that's the unpredictability of this disease. When you read about people, George, I saw him last week, he looked great. His doctor told him he had a normal stress test and he'd live forever. Oops, not so much. Sometimes that doesn't work out so well. And that's actually the commonest symptom is not chest pain for heart problems, it's sudden death. That's the commonest first symptom. So why is a heart attack important? I think everybody knows why it's important, because it can kill you. And if you survive it, then you can end up with heart failure. The heart doesn't work as well because an area of heart muscle is severely damaged. There's scar tissue in the heart, and this can form alternative pathways for the electrical activity. You get all kinds of rhythm disturbances. I'm sure some of you might have ICDs in place. That's meant to deal with those particular issues. And even if you survive your heart attack, that sets you up in future years still for a risk of dying suddenly without any warning at all. And so the whole thing becomes extremely important. And of course, this is the commonest first symptom in young men. This was a heart attack serial. It's a high cholesterol. I think it's cheese something or other. In any event, we've had this happen. People literally just fall into their meal. And this is 460,000 sudden deaths a year, and it's 60% of all heart attacks or heart disease deaths are sudden. So 40% survival from that first event. And 50%, I think this is the most telling thing here, 50% are male and 63% are women. So men survive it a little bit better than women do. And the majority are attributable to the heart just stopping working, called ventricular fibrillation. If you survive the heart attack, and for instance, if here's the heart attack here, this is what we see in the emergency room, and we can't open that artery, or you don't get to us fast enough, then that area forms scar tissue over a period of days, and you get this scar, this bulge in the artery in the left ventricle here, and then over time, that scar expands, what they call remodeling. The heart gets much bigger than it was before and becomes much less efficient. And that change from the small artery to the small heart to the big heart is kind of the definition, actually, of heart failure. And one of the real problems that we have if you survive the heart attack in the first place. And that's responsible for about $30 billion worth of hospitalization every year, 1 million hospital discharges. Incredibly significant problem, and one that we'd like to prevent from happening. And so we know it's a bad thing. We know how it happens: gradual accumulation of cholesterol under the surface of the arteries, inflammation, and then the signs and symptoms of it. I think the commonest one, the one that everyone thinks of first, is chest pain. And this would be when you describe chest pain to somebody, like a doctor, and someone puts their hand on the chest, that's got about a 60% predictive value that pain is your heart. If somebody says, I've got chest pain, and they put their hand on their chest, just that act alone has got about a 50-60% chance that pain is heart. And if they do this, they make a fist, doesn't matter what society they're in, it has the same, also about a 65% significance that a clenched fist is called a Vine sign. That pain is heart pain until proven otherwise. And that's almost as good as just a regular stress EKG. So that's a very, very predictive problem. The other symptoms: shortness of breath and fatigue. Fatigue is the commonest first symptom in women. They get tired. They don't get chest pain. And their exercise capacity drops. They can't do as much. There's no specific pain particularly. They just don't feel as well. And the location of the pain can be pretty much anywhere. Usually it's in the chest, but it could be in the low back. I've seen that happen. The upper back here, up in the jaw, not an unusual location either. And women certainly are different in the way that they have their pain. They'll have weakness, they'll have fatigue, they'll have nausea, whereas men will get chest pain and shortness of breath. So it's a very different problem. And the problem, of course, in women is fatigue is such a common problem that we all get from time to time. Distinguishing that from just the common, ordinary, benign or problems of fatigue is really, really tough. So you're sitting there and you get some chest pain, or you just feel badly, and you think you're having a heart attack. What should you do? And if you're at high risk, or if you've already had an event, you really should prepare for it. And the ways that you prepare, the heart attack action plan, are pretty much here. It's on the handouts, but call 911. And it's better to be safe than sorry, I mean, literally. If you're at risk and you're getting a chest discomfort that you've not had before, particularly if you break out into a cold sweat, if you feel short of breath, you have palpitations, you feel suddenly weak, or God forbid you pass out, then you got to call 911. Don't try to get to the hospital on your own. I mean, that's really silly. If you've got aspirin available to you, chew it. Don't swallow it, chew it. That's why it's actually probably best, if you're going to take aspirin, to use not the enteric-coated aspirins, but the cheap ones, because those, when you chew on those, they're rapidly absorbed, and that's really what you want to do. That prevents that blood clot from getting any bigger, and that really does work. If you've had a heart problem, you have nitroglycerin available, take it. Of course, you live in this area, you know the address of this hospital, so that's not an issue. If you've got a resting electrocardiogram around, bring it with you. as well as a list of your medications and particularly down this, a list of any allergies that you may have, or give that to your spouse or significant other or somebody else that's there present with you. So we know how it happens, we know what symptoms it causes, we know what to do if we get one. Now how do we prevent it? And the way you prevent it, of course, is by intervening on the risk factors that cause it. And the risk factors are everything you know already. I mean, you know you shouldn't smoke. You know that hypertension is going to cause a problem. You know that diabetes leads to heart problems down here. And you know that being overweight is something that combines the risks of all these other things as well. So that's the standard or classic risk factors. And add to that inactivity, an alternative diet, depression, or hostile or aggressive, behavior. Because if you don't like to stand in line, then get over it. Okay, and so it really is something that leads to trouble, no question about it. And there's two other things that have just come up in the past couple of years, actually ever since November of last year, and one is C-reactive protein. So apart from high blood pressure, apart from diabetes, apart from cholesterol problems, apart from smoking, C-reactive protein looks like it's an independent risk factor, and it's a blood test, and you're going to hear about it hopefully a lot from your primary care people, and they'll use it as another screening test. If you have a normal cholesterol and your CRP is high, then you're at risk of having a heart problem, even though your cholesterol is normal. The same may be true for vitamin D levels. If vitamin D levels are low, even though you may be taking it, may not be absorbing it properly, then that can lead to the risk of a heart attack as well, heart attack and stroke. So the doctors are going to be checking these two things in addition to your blood pressure, blood sugar, and cholesterol levels. And this is, the trial is called a Jupiter trial. We've had this CRP test around for a lot of years. I stopped using it back in 2003 because we didn't have a treatment for the thing. We knew that if it was elevated, it increased your risk for a heart attack, but so what? What could I do about it? And we didn't know until the Jupiter trial was published last November. And what that showed, that if this is at any given risk level, in other words, this is a calculation based upon a Framingham study. Framingham study was a study begun after Second World War in Framingham, Massachusetts, where they enrolled almost the whole town in a medical surveillance program where they followed their blood pressures and cholesterol levels and blood sugars and EKGs. Now they're down to the third generation that they're continuing to follow. And they develop predictors from that population of what leads to various disorders, heart problems, diabetes, high blood pressure, whatever. In any event, if your risk is 10 to 20% of having a heart attack within the next 5 years, then if your CRP level is high, greater than 3, then that risk is 25%, whereas if your CRP level is normal, it's only 15%. So even though you have a calculated high risk of having a heart problem based upon the Framingham score, if your CRP level is high, then that risk is double what your prediction should be. So that's really quite a valuable tool. And this is just looking at the survival curves of people with a low CRP and a low LDL. Those normal cholesterol and their CRP levels are normal. The survival over an 8-year period of time is like 99+%. Whereas if you have a high CRP and a normal cholesterol, there's a very significant difference. So as your cholesterol is normal, but your CRP is high, then you're at risk of having a heart attack. And the therapy for that, based upon the Jupiter trial, is to lower your cholesterol dramatically. We'll go over what the goals will be in that setting, but just to put that in perspective, if you have a high cholesterol and a high CRP, the differences are just amazing. So this was quite a study, in that we knew that if I couldn't find this slide, I tried to find it, but it showed the population of people that have heart attacks versus people that don't, and looked at cholesterol levels. And what it shows is that the curves are very close to each other. In other words, about half of the heart attacks that occur in people with normal cholesterols. And we couldn't figure out quite why that was true. And this Jupiter trial put that in perspective. And it's the CRP people that explain this. And so we now can identify pretty much everybody that's at risk of having a heart attack. The vitamin D thing is a little less clear in that we only have observational trials that look and see that if your vitamin D level is less than about 15 or so, it looks like you're double the risk of having a heart attack or stroke than if it's normal, above 30 or so. And the darker your skin, the higher the risk of having a low vitamin D. The only problem with it is that, so they looked at, Framingham was a nice way of looking at what the population is. About a third of people have a vitamin D level that's less than 15 that should be treated, and only 10% have normal above 30. The problem is that no one's done the study of actually giving vitamin D, raising the level, and show that that actually decreases the risk. Right now, we assume that that's true, but we haven't shown that to be true yet. So maybe it's a good idea to be on the stuff, maybe not. We just don't know yet. But most doctors, since it is a vitamin and easily done, are giving people vitamin D to raise that level, at least above 30, and in our office above 50. So how do you prevent a heart attack? Well, you prevent a heart attack by taking care of all those risk factors, basically, and identifying them appropriately. It's hypertension. That's the gasoline on the fire. If you don't correct the hypertension, then no matter what you do to the diabetes or the cholesterol levels, it's just going to gallop along. So high blood pressure is a really big problem. The high cholesterol is certainly one that we've learned about. A 1% reduction in the total cholesterol is a 2% reduction in risk. Let me make a comment about those population estimates. Whenever you see this stuff in the newspaper, this so-called, what are they calling it now? Evidence-based medicine. It's kind of a code word for taking care of populations and not taking care of people. So what they do is they say, well, everybody should be on this drug because that reduces the risk of having a heart attack by 30%. Well, what about the other 70% of people? What do we do for them? And they just kind of sidestep that whole issue because, well, there's no study showing that, so they don't put these all together in one lump sum. In other words, if you treat the hypertension, you treat the cholesterol, you treat the diabetes, and you treat the smoking, then you reduce the chances of having a heart attack in that individual down to maybe even 100%. Now, there's a chance of that person going on to have a cardiovascular event is virtually zero. So, and these are the ABCs. It was a little, I don't know where I got this slide from, but in any event, is aspirin seems to be an element of that. A1C control, that's diabetes, how good the diabetes is. B is blood pressure, C is cholesterol, D is diet, and don't smoke, and E is exercise. That's one way of remembering all this. The aspirin business is kind of a separate risk. It seems like if you're male, regardless of your risk factors, it's useful to use a baby aspirin every day. If you're a woman and there's no particular risk factors, probably isn't. In fact, it may increase your risk of having problems. So males benefit from taking aspirin, women may not, depending upon whether they have these other risk factors. So just taking it just because may not be a great idea. So this is just a summary of all those things, the things that we need to do to correct those risk factors, and you all know what they are, and hardly any of us do them. but we got to keep trying, and we're getting better at it. This is, I thought, was kind of cute. This is from Wiley, one of the non sequitur cartoons. Actually, tobacco was created as an intelligence test, which brings us to why you're here early. So, right, so I thought that was kind of cute. And the other thing that's not so cute is the reason in 1983, you don't know this, but the number of heart attacks in this country in women bypassed those in men in 1983. So that now women get heart attacks at a much greater rate than men do. And the reason is smoking in young women. They started smoking in the 60s, usually as a means of keeping their weight under control, and it's a huge problem. Now women outnumber men in heart attacks. Of course, walking the dog is another way to beat this problem. However, he's a little bit unclear on the concept. And of course, losing weight, that's a pretty obvious. I think this was up in Vermont at one of those roadside diners. This kind of put this all in perspective. Does diet really help? That's what I'm asking, asked in the office. If you change things, you eat more fish and you cut down on the saturated fats, does it really work? And this is a whole series of trials, 2002, 2003, 2004, 2005, thousands and thousands of people showing that diet manipulation decreases the risk of having a cardiovascular event enormously. So yes, it does. It really does. And we've shown it time and time again. So it's not just the Mediterranean diet. It's any change towards cutting out the saturated fats, keeping the carbohydrates in check, the simple carbohydrates in check. And this is a guy that I don't know who this is, but I have a number of patients that have done this. And this is a fellow who started off in September to November in a period of 2 months. His beginning cholesterol was 311, triglycerides 218, HDL pretty good at 68, bad cholesterol 199. And you know the goals, well, you will know the goals for a normal LDL should be about 100 or so. And all he went is from 185 down to 165, 20-pound weight loss in that period of time. And look what happened to his cholesterol, 311 to 144, cut it in half. Triglycerides, 218 down to 67. The good cholesterol went from 68 to 81, and his LDL fell from 200 down to 50. 200, 199 down to 50. And so does diet help? Does weight loss help? You betcha. You betcha. So putting those all together, and that's really, it's multiple risk factor interventions, getting all these things together, getting the blood pressure under control, getting the cholesterol under control, getting that blood sugar taken care of, and making the lifestyle changes. And the lifestyle changes really are diet. And the goals for all this are pretty straightforward. And for blood pressure, we choose less than 135 over 85 in most people. And if you've been in our office, you know that we actually have the patients do their own blood pressures, and we follow those over time, and that's a really nice technique. If you've got diabetes, then it should be even 10 points lower. And the rationale for that is the lower that blood pressure is, the lower the risk of developing not only a heart attack, but also developing eye ground, kidney, and neuropathy changes as well, particularly in diabetes. If the diabetes A1C is less than 7%, A1C is an estimate of what the average blood sugar is over a 3-month period of time. It's the amount of sugar that's on the hemoglobin molecule. And that's a very, very slow reaction that only responds kind of to the average blood sugar. And the normal is about 5.5% of hemoglobin has sugar on it. The usual diabetic that I'll see in the office will start off at 8, 9, 10%. So that's a fairly, cutting that down from say 10% down to 7%, cuts down the average blood sugar from about 220 down to about 140. That's the sort of change that we're looking for. And There's been some recent trials you may have seen in the newspaper showing that if you get too good control, that actually can increase the risk of having a heart problem or heart attack. And the status of that I don't think is very well clarified at this point. So I'm not so sure that I put much credence in that. But nonetheless, just beware that 7% is a pretty good target for most people. Cholesterol, total, you want less than 150. The bad cholesterol, the LDL, or the least desirable lipoprotein, LDL. If there's no heart problem, you like it less than 100. If you've had a heart problem, less than 70. And if you've had a serious heart problem, less than 50. And the rationale for those choices of goals are that 100 slows the progression. We know in a large population that if you get the LDL down to below 100, then you slow the progression of the narrowing in the artery. So if you're 90 years old, then slowing the progression makes some sense, that's okay. But if you're 50 years old or 40 years old, you don't want to slow the progression, you want to stop it. And stopping it requires the cholesterol to be down to about 70. And if you want to reverse it, you can usually get some reversal, and most people, when you get the LDL less than 50. So that's the reason for these various goals. The HDL looks like it might be as helpful, raising the HDL may be as helpful as lowering the LDL. The HDL is the highly desirable or good cholesterol. And what it does is it actually goes into the tissues underneath the surface of these arteries and pulls out the bad cholesterol. So kind of what they call reverse transport. So it transports the cholesterol out of the arteries. So if you raise that HDL, then you can have the same effect as lowering the LDL. Problem is, some people have very high HDLs, and yet they have a family history of heart problems. And those people have what they call atherogenic HDL. That HDL is bad HDL and can cause just as much trouble as the LDL. So just because you've got a high HDL level doesn't necessarily protect you from having a heart attack. Triglycerides are most significant in women, less so in men. The goal is generally less than 150 milligrams percent. Why that is, I think relates to the fact that the triglyceride level in women is more tightly related to the good cholesterol level. So the higher the triglycerides in women, the lower the HDL. So they have less of the good stuff around if their triglycerides are high. Happens in men too, but less of an issue. CRP levels, you should start asking your doctor what it is. 3 is average, so I put you at average risk. If you've had a heart problem, you want to be less than 1 milligram per liter. And those are reasonable guidelines. If you're 5 or 6 and you've got a normal cholesterol, then that cholesterol is too high for you. That's the only mechanism we have of treating that, and that's what the Jupiter trial showed us, that extreme reductions in the bad cholesterol level reduces the risk of a heart attack dramatically. The vitamin D level, normal is more than 30 nanograms per milliliter. If you're at high risk, then we want to normalize that, but we want to get you above 50. So we definitely want you above 30, but for most people, at least that's had a heart problem in my office, I want them more than 50. And the rationale for that is still to be determined. We don't really know that raising the vitamin D level actually prevents a heart attack. In a way we do. The only reason actually I pursued it is a rabbit trial. And what the rabbits showed was that vitamin D was really involved in the cholesterol metabolism in the inside of the arteries. And that's something we didn't understand before. So the higher the vitamin D level, the more efficient the HDL is in getting the cholesterol out of the tissues. So it makes a lot of sense, as well as we have 4 trials that say that this probably is a really good thing to do. So you're doing everything right. You got your blood pressure is 120/80. Your bad cholesterol is less than 70. Your good cholesterol is more than 40. Your blood sugar is normal. Your weight's reasonable, and your exercise. How much can you prevent a heart attack? Now, how good is this? So when you do all these multiple interventions, how much can you reduce a heart attack? Over here is people that, this is Framingham again, people who have never, or families that have never shown evidence of heart disease, and this is various systolic blood pressure levels. So blue is 110, and this kind of off yellow or orange is 180. So that over a 5-year period of every 100 people, then you have about 3 people with a blood pressure of 180 are going to have a heart attack. Whoa, not very much. Big blood pressure, but not very much. Whereas when you look at people who have had a total cholesterol of 270, really high, who smoke and have a low HDL, they have about a 20% chance of having a heart attack if they have high blood pressure, and if they have a normal blood pressure, only about an 8% chance. So if you take all of these things, a 60-year-old diabetic male with a low HDL, which is a big population, who smokes and has high cholesterol, then you're talking about a 44% risk. Now, is that every 100 people over 5 years, 44 of them are going to have a heart attack versus 3. So that's your risk reduction. So if you correct all those things, except the male part. But of course, this is San Francisco. You can go from 44% down to 3%. So that's a pretty substantial change. So that's the level of risk reduction that you can achieve doing this. This is a thing I came across the other night, just kind of looking around, and this was just amazing. This is a restaurant down in Tempe, Arizona. It's called the Heart Attack Cafe, and all the waitresses are dressed as nurses. Okay, and the banner across the top of the website is, if you're over 350 pounds, you eat for free. Okay, and they have the single bypass burger, the double bypass burger, the triple bypass burger, quadruple bypass burger, and no filter cigarettes, flatliner fries, and Jolt. And I thought that was, it kind of presents a dietetic extreme from which I think our dietitian can kind of bring us back to reality with. But in reality, yeah, we already know that you're really shooting the dice with this sort of stuff. This place really exists. I mean, it's amazing. It's just amazing.
Yes, someone told me that the ratio of HDL and LDL is more important than the absolute level of HDL and LDL. Can you comment on that?
Yeah, the ratio between total cholesterol and HDL. That was, it was a big trial. It was American airline pilots. It was done maybe 30 years ago. They followed all these guys for a long period of time, and nobody developed heart disease if their ratio between total cholesterol and HDL was less than 3. Okay, so you had a total cholesterol, say, of 200, and if your HDL was 70, then you didn't get heart trouble. And maybe people are going back to that, sort of, and they're looking at the ratio between the protein that makes up HDL, it's called ApoA, and the protein that makes up LDL, the bad cholesterol, is called ApoB. They're looking at ApoA and ApoB levels, and the ratio between those two is a better predictor than either one alone. So yes, you're right, but it's not really crept back into the mainstream care yet, but it's getting there. It's getting there. Yes?
Yesterday, reading on Google, there's a new study came out of Australia saying that ibuprofen could be bad for heart.
Yeah, could ibuprofen be bad for heart? In general, all the non-steroidal anti-inflammatory drugs, of which ibuprofen is one of the first, It causes fluid retention. It raises your blood pressure. It can cause kidney problems long term. My own take on it is that everybody has a certain number of ibuprofen they can take during their lifetime. And if they take one more than that, their kidneys go right down the toilet, so to speak. Yeah, it's like cortisone. It's all the things that get involved with the immune system. But as far as heart's concerned, it seems to interfere with aspirin in some way and its effect on platelets, so it's not good to take together. Causes rhythm problems. Not much good to say for it, actually.